Good afternoon, everyone. My name is Chelsea Lynch from NQF. Thank you for joining us. Please review the housekeeping reminders and we'll get started in just a couple of minutes. Good afternoon, everyone. We'll get started in just another minute. Just give people a few more seconds to get signed on. All right, I think we can go ahead and get started. Victoria, can you advance to the next slide, please? Hello, everyone, and welcome to the first web meeting of the Leveraging EHR Source Measures to Improve Care Communication and Care Coordination option year. My name is Chelsea Lynch, and I'm a Director in Quality Innovation at the National Quality Forum. We truly appreciate that you all joined us today and that all of you are prioritizing this work within your busy schedules. Additionally, we'd like to thank CMS for funding this important work. This year, we will be building on our work during the base year and work together to develop practical, actionable recommendations to move the care communication and care coordination quality measurement field forward. We'll also discuss the objectives and plans for this new phase of work in a few minutes. I'd like to share a few housekeeping reminders before we get started. We're using the WebEx platform, which has audio and video capabilities. Please place yourself on mute when you're not speaking, and we encourage you to keep your video on, especially when you are speaking. Please use the chat box to communicate with NQF staff and with each other. Additionally, please use the raise hand feature during our discussion to be called upon to speak. We'll also periodically ask for comments from people who are dialed in. We will do a committee roll call shortly. But first, I'd like to introduce NQF's new President and CEO, Dana Gleb-Safran, and invite her to provide some welcoming remarks. Dana?
Good afternoon, everybody. I am really delighted to be here today and welcome the members of the EHR Care Coordination Committee and the members of the public to our first web meeting for the option year. NQF is excited to continue this collaboration with CMS and all of you to advance this important work and explore how EHR source measures can facilitate and improve care, communication, and care coordination. Effective care communication and coordination, as we all know, are absolutely vital to achieving improved health and improved healthcare quality. They are probably among the greatest pain points we hear from patients when we talk with them about the challenges they face in getting healthcare and with the delivery system. The idea that care just feels fragmented, that the left hand doesn't know what the right hand is doing. With the emergence of EHRs as important sources of data for measurement, this work is so important to explore how EHRs can be leveraged both to improve care communication and care coordination and to improve the measurement of these. In the first year of this work, the committee helped to describe the current state of using EHRs to measure and improve care coordination and care communication with an environmental scan. And in this option year, The committee will build on that foundational work to develop recommendations that facilitate and improve EHR-based care communication and coordination measurement with all-payer, cross-setting, fully electronic data approaches that might really drive improved quality and improved health outcomes. So I want to thank this committee and our federal liaisons for the ongoing engagement in this important work. And also really a special thank you to our committee co-chairs, Dr. Jerry Lamb, Dr. Richard Antonelli, for their leadership and commitment to this important work. I really look forward to the insights and recommendations that come out of this committee's discussions throughout the year. And at this point, would love to just turn it back to Chelsea. Thank you.
Thank you so much, Dana. We really appreciate you being here. I'd like to turn it over to our co-chairs. Why don't we start with you, Rich?
Good afternoon. This is Rich Antonelli. I also want to express my sincerest gratitude to CMS for allowing us the opportunity to continue the work of year one. Jerry, you've been a wonderful co-chair, and our NQF team, Chelsea and all of the other team members, it's been great. But I really want us to lean into this work. I think many of us felt year one, as Dana Safran just described it, was sort of describing the status quo. And I, for one, said, okay, if that's the menu, I'm still really hungry. So today starts year two, where we actually start to say, and what are we going to do to alleviate that hunger? And Dana, so accurately, every person that I know always wonders about the left hand and the right hand when it comes to their care or the care of their families or friends. So with that, I'm looking forward to tremendous engagement by our entire diverse committee. Thanks again to NQF staff and to CMS for this opportunity.
My turn, Chelsea?
Sure. Thanks, Jerry.
So Jerry Lamb here, and welcome back, everybody. We are just so delighted that we're back together to advance this work, both as Dana and Rich were saying. And thank you, every one of you, for being here. You are so critical to this work. Like Dana and Rich, I want to thank NQF. We have a phenomenal team that we are working with who is committed to this work and to moving it forward and to the recommendations, and to CMS for funding this opportunity. I know we all had our fingers crossed that this was going to happen. So the fact that we're all back together and we get to move into recommendations is just so important. So I'm looking forward to our discussion today. You know, as Rich and Dana were saying, we're going to do a lot of stage setting here. We have approximately 6 meetings to do some really critical work together, and we will be working at these meetings, between the meetings, and like Rich was saying, we're going to encourage each and every one of you to be very, very active, share your expertise, share your insights, and we're going to have a whole bunch of ways to do this, whether it be in chat, whether it be in the discussions. But this is going to be a great year, and we are just so excited to have this opportunity to make recommendations. So yay us, and let's move on.
Wonderful. Thank you both. Next slide, please. So I'll briefly go over our agenda for today. After taking attendance and sharing any disclosures of interest, we'll provide an overview of the project and timeline, as well as outline everyone's roles and responsibilities. We'll then have our first discussions around themes identified in the base year and initial discussions on recommendations. As always, we'll leave a few minutes for NQF member and public comments, and we'll wrap up with next steps. We'll get started with our introductions and overview of meeting objectives. As Rich and Jerry already highlighted, I am very fortunate to be joined by a wonderful team here working on the project. New to our option year is Udara Pereira, a senior manager. herself, as well as Monica, Victoria, and Jesse, have all been incredibly helpful in their hard work, and will continue to work with them throughout the rest of the option year. I'd also like to acknowledge and thank Kim Rawlings and DeQuincy Polk from CMS for their support on this project. And as I mentioned, the objectives for today's meetings are to introduce everyone to the goals of the project and start our discussions for the development of recommendations to leverage EHR source measures to improve care communication and care coordination. You'll see the approach this year will be very proactive and very interactive, as all of the recommendations that are developed will be based on our committee discussions. Before we get started, I'll quickly go over some ground rules for our meeting today. As you know, we want to emphasize that there's no rank in the room. Everyone's opinions and insights are valuable. This is a complex topic, so your experiences are critical to the advancement of our work. Please share your experiences and learn from one another, be respectful to other committee members, and create space for different perspectives. Additionally, please refrain from making any political jokes or comments. We'll transition now to committee attendance and disclosures of interest. Before we begin roll call, a few words about disclosures of interest. To promote transparency before we get into the work of the option year, we will ask everyone to share any relevant disclosures of interest you may have related to the work of the committee. This could include engagement with CMS, research funding, consulting or speaking fees or honoraria, any ownership interest in a relevant organization, and any other relationships, affiliations, or roles that you think would be important to disclose. We have reached out to all committee members via email in advance of today's meeting to complete a new disclosure of interest form. If you have not yet submitted your form, please do so as soon as possible after the meeting. Today, we will ask everyone to orally disclose any information that you have provided or will provide that you believe is relevant to the subject matter before the committee. You'll see an example on the slide for an introduction and a disclosure. Just a few reminders before we get started. You sit on this group as an individual. You do not represent the interests of your employer or anyone who may have nominated you for this committee. We're not only interested in your disclosures of activities where you are paid, but also unpaid. And just because you disclose something does not mean that you have a conflict of interest. We do oral disclosures in the interest of openness and transparency. With all of that, I'll pass this over to my colleague, Victoria, to take role and facilitate introductions. Victoria?
Thank you, Chelsea. I will now go through the roster, and like Chelsea mentioned, I will have everyone go through and please disclose any of the interests that you've either already sent us or will be sending us. I will start with our co-chairs. Rich Antonelli.
Nothing to disclose.
Thank you, Rich. Jerry Lamb.
Victoria, I love that little blurb there about how to do this. I'm Jerry Lamb, and I am a professor at Arizona State University. And as I disclosed on my COI, I do consulting and I write about care coordination. I'm also engaged in a project that is looking at improving primary care with care coordination as a critical component of it.
Thank you, Jerry. Kathleen Balistracci.
Yes, hi, Katie Balistraci here. I am research faculty at Yale University and a senior health outcomes researcher at the Yale Center for Outcomes Research and Evaluation. I lead the development of quality measures under a contract with CMS and have no COI.
Thank you, Katie. David Brianek. Brian Buys.
Hey everyone, Brian Buys. I'm a Vice President of Product Management at Point Click Care. We are the leading EHR in North America for nursing homes and senior living facilities. We also facilitate care coordination through an acquisition about a year ago of a company called Collective Medical. So we are increasingly across the senior care continuum focused on care collaboration and communication. So it's a privilege to be here, be part of this group, and no further disclosures.
Thank you, Brian. Sherry Costa.
Hello, this is Sherry Costa. I'm the regional manager of our support services at Ascension in Wisconsin. that I oversee our navigators and social workers for our oncology service line. And I have no disclosures.
Thank you. Cynthia Cullen?
Hi there, Cindy Cullen. I work at Mathematica, where I am a senior director for business development. Much of the work that I do is to oversee a portfolio of measure development and maintenance projects, many of which are sponsored by CMS, specifically CCSQ. That is the only disclosure that I have. Thank you.
Thank you. Keith Horvath? David Key? Joseph Kunish? Russell Leftwich?
Hi, Russ Leftwich. I'm a senior clinical interoperability advisor for InterSystems, a data technology vendor, and I have no new disclosures otherwise.
Thank you. Michael Lieberman? Brent Perry?
Yeah, good afternoon, good morning, wherever the case may be for you. I'm Brent Peary. I'm the Vice President for Chaplaincy Services for Memorial Hermann Health in Houston. And for a little over 12 years, I've been a paid consultant with the United States Navy Bureau of Medicine and Surgery, working with their healthcare chaplains in the areas of quality and documentation. I have no other COI.
Thank you, Brent. Rebecca Perez?
Good afternoon, good morning. I'm Becky Perez. I'm the Senior Manager of Education and Strategic Partnerships for the Case Management Society of America, and I have nothing to disclose.
Thank you. Ann Pollock? Walter Rosenberg? Stacy Schilling? Sue Ellen Shea?
Yes, that's correct. Good afternoon. I am a senior clinical consultant at Cerner, which is an electronic health record, and I have nothing else to disclose. Thank you.
Thank you. Colleen Scow? Alexis Snyder?
Good afternoon, everybody. I'm Alexis Snyder. I'm a patient, family, and community engagement specialist in the Boston area. I work with a number of organizations locally, regionally, and nationally with a focus on health IT and patient-centered outcomes research. And I have nothing to disclose today.
Thank you. Maureen Stewart?
Good afternoon, everybody. Thank you so much for having me back. I'm excited to be here. I'm from West Virginia. I'm a former case manager at BCPA and now a full-time caregiver to a daughter with a severe epilepsy. And I have nothing to disclose.
Thank you, Maureen. Jason Weisner? Dorothy Winningham?
Hello, I'm Dorothy Winningham with the PFCC Partners Network, and I have nothing to disclose.
Thank you, Dorothy. Kim Yu?
Hey everyone, my name is Kim Yu. I'm a family physician, also a regional medical director for Aledade. We work with independent primary care practices and have over 800 practices and 150 community health centers that we work with, doing care coordination, also lots of work in value-based care.
Thank you, Kim. Andrew Zinkel?
Hi, Andrew Zinkel, Medical Director of Quality at Health Partners Health Plan, and also Professor of Emergency Medicine at the University of Minnesota Medical School. I have no disclosures.
Thank you so much. Okay. Has anyone else joined the call that would like to share their disclosure of interest? Okay. In that case, that wraps up our roster. Thank you, everyone. I will now go through our federal liaisons. If you are on the call, please feel free to let us know that you are here and on. Joel Andrus. Tiffany Gillis Brown. Kyle Cobb. Chris Dimmick.
I'm here, thank you.
Thank you. Tara McMullen.
Hi, I'm here. Thank you so much.
Carly Madosh. Francine Sandro.
I'm here.
Thank you. Kenneth Yale. Okay, thank you. And I will now turn it over to Yadara Pereira.
Thanks so much, Victoria. Over the next few slides, I'll go over some of the project purpose as well as the timeline that we'll be going over for this option year, as well as the roles and responsibilities of the various individuals that are part of this project. So the purpose of this project is to identify the best practices for leveraging EHR-sourced measures to both improve care communication as well as care coordination quality measurement within an all-payer, cross-setting, and fully electronic manner. So last year, we had the base year, which resulted in the development of an environmental scan that describes some of the current practices that are in use by a variety of different stakeholders, which includes clinicians, organizations, payers, patients, and technology companies, in order to leverage EHRs to both measure and improve care communication and coordination. And this year, we've started the option year, where we'll build on that foundational work that we did during the base year to try and develop consensus-based recommendations that facilitate and improve EHR-based care communication and care coordination quality measurement within an all-payer, cross-setting, and fully electronic manner. And so this year, our final deliverables will be two final recommendations reports that we'll go over in a little bit more detail in the next few slides. So during the base year, we recruited and selected our wonderful committee members and federal liaisons. We also convened committee web meetings, and we held 4 web meetings during the base year to help inform the development of the environmental scan. With your help, we developed consensus definitions for care communication and care coordination and explored the relations between care communication and care coordination, EHRs, and improved outcomes. We also discussed the impact of social determinants of health on care communication and care coordination and measurement, as well as the advantages and challenges of measuring care communication and care coordination in EHRs. We also conducted expert interviews, where we had 9 expert interviews to help inform the development of this environmental scan. And those interviews were held with individuals with expertise in measure development, care coordination research, EHR development, community-based care coordination, social work, the patient experience with complex care, federal regulations, and clinical informatics. We also produced this environmental scan, which is a high-level, non-technical, visually appealing report with an educational tone. And we included within that environmental scan appendices, which included a literature review and a measure scan. So we've now kicked off our option year. And through this option year, we plan to have 6 2-hour web meetings where the committee will develop consensus-based recommendations for how EHRs can better facilitate care communication and care coordination, how existing and future development of EHR-sourced measures can be leveraged to improve care communication and care coordination, how to address social determinants of health data collection by EHRs as it relates to care communication and care coordination, as well as possible EHR-sourced measure concepts that are related to care communication and care coordination. And this includes both novel or respecified existing measures. I do want to draw your attention to the bottom of the slide where we have the definitions for what a measure concept is, as well as what a measure is. So a measure concept is an idea for a measure that includes a description of the measure, which could include things like the planned focus and the target population. Whereas a measure is a fully developed metric that includes the detailed specifications, and it might have also undergone scientific testing. Also, all of these committee discussions from the web meetings will be distilled into consensus-based recommendations and conveyed in 2 final recommendations reports. So we'll have both the final report as well as a shortened final report. And that final report will be at least 20 pages long and will be very detailed and technical. And we'll also have a shortened version of that final report, which will be no longer than 10 pages. And it will be visually appealing, engaging, and non-technical with an educational tone in order to try and disseminate this information to a wider audience. On this slide, you'll see the project timeline for the option year. So today we have our first web meeting, which, as you know, serves as an orientation to this option year. And later on during this meeting, we'll start to develop recommendations. We'll then continue the discussion of these recommendations during the next 3 web meetings that will be held in January, February, and March of next year. In April, we'll submit drafts of the final recommendations report as well as the shortened final recommendations report to CMS. In May, the committee will review the drafts, and during our 5th web meeting, we'll solicit feedback from the committee on the drafts. In June, we'll then be updating the drafts based on the committee feedback that we've received. And in July, these reports will be open to public comment during a period of public comment from individuals. In August, during our last web meeting 6, we'll then adjudicate those public comments and finalize the drafts of both of the recommendations reports. And in September, the final reports will be posted. Over the next few slides, we'll go over the various roles of individuals that contributed to this project. And this slide lists the roles of committee members, which is defined as serving as subject matter experts, working with NQF staff to achieve the goals of the project, reviewing meeting materials in advance, and participating in all of our scheduled web meetings, working towards meaningful consensus with fellow committee members, reviewing the draft deliverables, and providing all of your input and guidance on recommendations for the final reports, as well as providing additional feedback and input on deliverables as needed, and responding to public comments that are submitted during the review period that we just went over. And so there are 2 ways to provide input during web meetings. The first is to verbally share your input and your comments with the committee, and the second is to use the chat box in order to type in text, which the committee, as well as everyone that is participating in the meeting, will be able to see. Outside of meetings, you can also provide all of your input by submitting additional input and feedback that's related to committee discussions via email either before or after the committee meetings, as well as providing written comments on draft deliverables during committee review, so May and July of 2022, and participating in offline work. So for example, things such as survey questions as applicable. I do want to pause here and ask the committee if there are any questions in terms of their roles, as well as any additional roles that the committee would like to identify for committee members. Okay, hearing none, I'd like to move on to the next slide. Where we'll now go over the role of our committee co-chairs. Our co-chairs try and help us by facilitating the committee meetings and participating as committee members, as well as keeping the committee on track to meet the project goals without hindering any critical discussions and input. And they also assist our NQF staff in anticipating questions and identifying additional information that can be useful to the committee. The role of our federal liaisons are to serve as a resource to supplement the committee discussions and provide their valuable input on important topics such as details on federal programs, the statutory requirements, the practical consideration of data needs, and any ongoing challenges that are confronting federal programs. We also ask that they review and evaluate our project deliverables. So for example, they'll look at things such as the factual accuracy of technical descriptions of how quality measures are used in specific federal programs. And the role of our NQF project staff is to work with you all, the committee, to achieve the goals of the project. So that includes facilitating meetings and conference calls, ensuring that there's adequate communication among all of the project participants, facilitating necessary communication and collaboration between different NQF projects and external stakeholders, and responding to our NQF member and public queries that we receive about the project. We also maintain documentation of our project activities and draft and edit all reports and project materials, as well as publish the final report. And last but certainly not least, the role of NQF members and the public is to engage in the work by reviewing draft reports and providing feedback to both NQF and the committee during the public commenting period in July 2022 and participating in web meetings during opportunities for public comment. Are there any questions or comments on the overview of the project, the timeline, or rules of anyone? Okay. Hearing nothing and seeing nothing in the chat, I'd like to now pass it over to my colleague, Chelsea.
Can you hear me?
Yes.
I think I was on double mute for a second. So in addition to what Udara shared, just to set the expectations so you kind of know what you're getting into for our meetings in January, February, and March, that is where a lot of our discussion will really be digging deep into our recommendations. And we are anticipating to use breakout groups, and so using smaller groups to have more in-depth discussions, and as well as provide some discussion guides in advance, similar to the base year themes that we shared ahead of time, just so you're able to come to the meetings prepared. We, as you saw, it's a pretty short timeline with just a few meetings, so really just want to make sure that we're making the most out of our time. And we encourage everyone to, as always, we did this in the base year already, but use the chat if you think of anything, either before the meeting, during, or after. Please feel free to share that via email with us, and we'll make sure everything gets captured. So just wanted to let you know, reiterate some of those ways that you can make sure that you're engaged. So I will pause again just to see if there are any questions, and then we'll get started. Okay, so we are going to get started with an overview and discussion on the themes identified in the base year. These themes were pulled from our previous web meeting discussions from the environmental scan report, literature review, and measure scan. We want to use today's discussions to set the foundation for our work over the next 3 web meetings in early 2022. As you saw in our timeline, we have 4 meetings, including this one, to start developing the recommendations that will be in our final report. We really want to make sure our discussions are very intentional. To help develop the recommendations, these themes will serve as the discussion topic areas in our future meetings. As a reminder, we're working to develop practical, actionable recommendations that will assist the field in truly being able to leverage EHRs to measure and therefore improve care communication and care coordination. On this slide, you'll see the 10 themes we've identified. We'll dig into each theme individually, but wanted to provide a quick overview to set the foundation. The themes are availability of data in EHRs, sharing EHR data, barriers in using and sharing EHR data, equity considerations, need for a single or overall care plan, role of EHR-based tools, measurement considerations, measure endorsement barriers, need for standardizing SDOH data collection, and considerations for machine learning algorithms. For each theme, I'll provide an overview before Rich and Jerry facilitate our discussion. We'll want to look at the themes collectively and individually. We want to consider what gaps are present, if any theme should be refined or expanded, if any theme should be prioritized, or if there are any themes that are overarching and should be a consideration across all recommendations. We'll also start to identify any recommendations that come to mind for these topic areas. We have a lot to cover, but we'll be just starting to scratch the surface, and we'll have time to dig even deeper in our next meeting. So we'll start with our first theme, which these are in no particular order, but that theme is the availability of data in EHRs. For us to be able to leverage EHR source measures to improve care communication and care coordination, the data first needs to be available within the EHR. So this theme is looking to examine topics such as how data can be incorporated into the EHR from various sources, such as clinicians, mobile devices, and wearables, how to capture care communication and care coordination activities for roles that do not document within an EHR, as well as how to capture community-based activities, how to identify all team members involved in a patient's care, and in a standard data set to include necessary information for transitions in care. So I'll go ahead and hand it over to you, Rich.
Thank you very much. And I want to sort of launch into this and keep in mind those discussion questions, right? We're looking at work that we did in year one, gaps, points for prioritization, need for refinement, overarching opportunities. And the recommendations we make today is actually for moving forward to the next stage. So we're not necessarily looking for measures to be endorsed. So this is going to be one of the important dynamics of our year to work together. So let's open this up. You can use the hand raising functionality, and then the staff will flag for me. Jerry will take over on the latter portion of each of the first 5 topics, where we will have a parking lot of recommendations. But I'd like to open this up, thinking about this first theme from year one. What are people's thoughts about, did we get it right? Is it sufficient? Are there gaps? What needs to happen? Russell?
Yeah, this is Russ Leftwich. Do we have, for our purposes, a definition of the EHR or EHR and EHR? Because among these bullet points, it says how to incorporate, how to capture activities for those who do not document in an EHR.
So I think for the purposes of our discussion today, an EHR is any sort of electronic record that is kept for patients. So this is coming a little bit more from the healthcare provider side or health system side, not necessarily a personal health record, that would be on the patient's aspect, but really from an EHR that an organization would have, if that makes sense. Does that answer your question?
Partly, but I guess I am particularly trying to resolve the question of what about an electronic record that spans organizations like a health information exchange that has an aggregated electronic record for individuals.
I see. So I think, and any of our measure developers have a little bit more familiarity with this aspect. I think since we're essentially looking for EHR sourced measures, I have a feeling that will be at the individual level, but I certainly think if there's anything that health information exchanges, it may make sense from a measurement standpoint, we could do that as well.
So once again, that's ambiguous as to what the definition of an electronic health record is, because one might think of health information exchanges that create an electronic record for individuals of their health data as an electronic health record.
I see. So I think we are looking at the tools used by clinicians, understanding that that information could also be shared with HIEs. So the main focus being how to get that information and that data into an individual's health record.
With all due respect, I think that information goes in the opposite direction.
Okay.
From the EHR to the health information exchange, which once again might be viewed as an electronic record because it is of an individual's health data.
Right, and I do see, Christine, I stand corrected, Chris. Yes, HIEs are also used by clinicians. We are focused on ones used at like the point of care, understanding that could also be health information exchanges. And I think I might be having a difficult time kind of understanding the but the miscommunication in this piece. Are you just thinking electronic health record as we're saying this is just too broad?
No, I'm saying it's much too narrow.
Too narrow. Okay.
Because that health information exchange as a aggregate record of an individual is also used at the point of care for those individuals.
Okay, and then
in many cases, viewed as a window, if you will, in the organizational EHR.
I see. That's a helpful perspective because we are looking at how to improve care communication and care coordination by leveraging EHR source measures, which can happen both at the individual level and how do we make care communication, care coordination, measure that for individuals, but then also for patients like from a health information exchange or a larger field of data. Is that right? Does that sound right to you?
Right. I mean, I think of that health information exchange as longitudinal representation of the individual's data as a electronic health record as well, and it is accessed at the point of care.
Russell, this is Rich Antonelli. I really like where you're going with this. I want to acknowledge that I got Brian and Kim in the queue, but Russell, you're putting your finger on something that is especially appealing to me. Excuse me. This will actually cross-cut potentially to other themes, like what are the data that are within there. But I think if you could give us a statement about what you'd like to distinguish EHRs from the HIEs and how they relate to each other, because what I'm hearing you say is there is absolutely a dependence there to improve coordination of care and communication. But I absolutely want to capture this, and Jerry will be helping to refine some of the recommendations. But tell us what it is that you're recognizing as a gap in the way this theme is being framed.
So I think the more complex the individuals are who are patients, the more complex in their list of conditions, if you will, the more likely they are to have care in multiple organizations, documented in multiple different organizational EHRs. And from the standpoint of care coordination, the fragmentation of their documentation is an enormous problem. Both documentation of care and documentation of care plans, of which those complex individuals often have several, and coordinating their care is, for those individuals, a huge part of it is a cross-organizational, if you will, communication, exchange of data, and ideally the ability to see their electronic record as an aggregated record, not a several different records, right?
Yeah, I think I'm tracking with you conceptually. You know, what I'm hearing you say is, how do we get to integration? And one way of getting integration is to make sure that the data is able to move from institutional EHRs up into the HIE. For the staff, and I'm sure that our staff is, I want to call out to the committee, there are some suggestions in the chat. This is really, really important and foundational. And Russell, I want to thank you for calling that out. And staff, if you could please take note of this. I'm going to move on to Brian and then Kim in this space. Brian, first to you.
I just, in support of Russell's description, I think we think of EHRs as maybe cells within the organism that support, and there's a lot of interstitial fluid that we're talking about, or interstitial communication, or things that move between cells. And so if you look at the health IT world, there are a number of product segments around virtual care or other things that capture, I think, the sentiment of a lot of this care coordination and communication. And I think there might be room for, availability of data in EHRs and other health IT communication tools, or something to that effect. We could maybe be more specific about the market segments or product segments that represents. But I just wanted to support that. I think a lot of what we're putting our finger on is the missing information in between EHRs versus the availability of data within EHRs. So just in support of Russell's comment.
Yeah,
I like
both
that.
points very well taken and really critical. Kim, to you.
Yeah, I was just going to echo that, having other sources of data, including the data from your EHRs, can be really helpful in being able to get the whole view of the patient. And so having integration from HIE, from other population health tools, whether it be like something like Alade's tool or I2I or whatever it is that you're using from a population health standpoint, can be really helpful. The second thing that I think is from this is not just availability of the data in the EHRs, but the quality of the data in the EHRs. And is the type of data that is actually given to the physician really high quality and high yield? Or is it just, I think there's definitions as to the types of data that EHRs provide and the quality that it actually gives to the practice.
Let me ask you to keep going with that notion of quality of the data. As a clinician, I think I know what you mean, but I'd like you to be a little bit more explicit, please.
Okay. So understanding not only the veracity and the validity of the data that is accurate, that is actually the patient's data, right? When you have data that it comes across from multiple different sources and you're trying to ensure that it is the same patient, that data actually is attributed to that patient. And I've seen this in multiple different areas where you'll get a patient and they have the same name, but not the same birth date. And then the wrong data gets attributed. So I think it's important that we actually call that out to ensure that the burden of accuracy is not on the practices to try and figure out whether it's accurate, but that there is some element of feedback that goes to the EHR companies as to the quality of the data that they're actually providing the practices. I think also the availability of data, one thing that's missing also from here is the cost of the availability of data. What is the data that is necessary that practices should definitely have access to? What is it that, EHRs charge, right? And HIH charge. And so, you sit there thinking, well, for care coordination, shouldn't the physician have access to all the information on their patient? And should they really have to be charged for that information when it actually is for the patient's benefit to be able to get that access?
That's very helpful. And Russell, I don't know if your hand is still up or up again. It's still okay. So I'll get to you in a minute. I just want to emphasize some of these. So Kim, I really like this. And in fact, every time I sit in meetings around social determinants, the accuracy of the data and the data provenance are really, really important in that space. So I'm gonna what I'm gonna do is to deduce from your comments the quality of data includes both validity, provenance, and you potentially teased out this notion of what data need to be available, and that gets us toward this the notion of completeness of the data. So accuracy, completeness, and potentially provenance. Thank you for that comment. Russell?
So I was going to comment on the problem of data quality, which if you're in the business of sharing health information data is an enormous problem that often takes up most of a conversation. I've been involved in a project the past year convened by the Sequoia Project, which is the entity that operates the nationwide e-health exchange, among other things. And that over a year now long project was convened around the data quality issues in trying to exchange information at the nationwide level. And I will cite a conversation I had a couple of years ago with someone at the VA in the part of the VA that's responsible for exchanging data between the VA and community organizations, if you will. And they were identified the VA at the time, and probably still, as the largest or the organization with the most data exchange partners of any in the country, because they had over 200 organizations they exchanged data with. And they were paralyzed by data quality issues, that it was very difficult to use the data because of, as was just mentioned, that just matching the right patient with the data, but beyond that, issues of coding of the data or miscoding of the data, or not coding the data, and being unable to use data because it's just uninterpretable. So that, I think, is in the, quality measures realm also a problem, that if you're collecting data from different places, you can't count on data quality.
Yes, yes. Hence the notion of provenance. Thank you. I've got Alexis, and then Jerry Lamb, you're in the on deck circle to get some recommendations after Alexis makes her comment. Alexis?
Yeah, I just wanted to add to the conversation about the quality and accuracy piece. And I think I probably brought this up a bit during our work last year. I would say that quality also expands to the not just the accuracy of coding or the accuracy of, is this information in the right patient's chart? Did it get put in the wrong patient's chart? But more so right back to the beginning with information on the particular patient that sometimes is inaccurate in the record. So sometimes there's medication errors, there's test errors, there's clinical notes that are inaccurate. And I think that that's a big piece of the picture that we need to be concerned with when we talk about accuracy and quality, because the care coordination isn't going to help anybody if the information for the complex patients, even more so, is inaccurate from provider to provider.
Yes, this is really, really, really important. So it's not just the availability of the data, it's the quality of the data from different sources. And we heard this discussion about EHRs at the institutional level to an HIE. So Jerry, we're going to follow this dynamic. I'm going to hand it over to you to suss out some recommendations. My observation is this, though, this past few minutes on this singular initial theme will resonate with other themes. So I want to assure the committee members and the staff that I think we're doing okay for time. So Jerry?
Thanks, Rich. So what we're going to do here is we're not going to the specific recommendations, just a ballpark of priorities and what, Rich and I and the NQF team have been talking among ourselves as kind of the small R recommendations. So how important is this? What do we need to get on the table? So let me just summarize what I've heard so far in this theme of availability of data in the EHRs. Some of the missing gaps have been looking at the definition and the difference between EHR and HIE. It's also looking at the relationship between the EHR and HIE to get to what many of you have put in the chat is the aggregate record of the individual. We've also been talking about quality of the data. So it's not just availability of the data, it's looking at the characteristics that you've all identified of accuracy, completeness, provenance, and I think the last comments were about meaningful data. And then Rich's last comment is that we have 10 themes with a lot of interaction with that among our themes. And so just let's kind of tease out here as we move forward to kind of small R recommendations that we need to consider related to this, such as define EHR, HIE, and the relationship. And I'm just putting them out there. I'm not saying they are the recommendations. What Rich and I need to kind of move through this is where are the gaps, what needs to be refined, and where are the recommendations. And Brian, I saw your comments, and so we will be getting all of that in chat so that we can factor that in. So who wants to speak to small R recommendations related to this theme about what are the things that we need to kind of move forward in thinking about as recommendations as we move across our meetings? Okay, HIE, there's a lot of HIE in the chat. Fran, Alexis, Brian, so are you making recommendations that HIE needs to be in here? Kind of clarify a little bit. What are you putting forward here about recommendations? Or are you just telling us that HIE is a health information exchange?
Jerry, I think it was just defining HIE for one of our committee members.
Ah, got it. Okie doke.
Yeah.
Brian, you got your hand up. Go.
I would just say, I think we might be getting a little hung up on HIEs in particular as a mechanism of communicating between EHRs. There are other categories of those mechanisms, class, which ranks health information technology, specifies population health, patient engagement, telehealth ecosystem, and some other things. We may actually want to look at those definitions for class and actually find some of the information that we're looking for there. It's really not just about the EHR, it's about the EHR and satellite tools that a healthcare entity is using in their totality. And so most health systems will have an EHR, but they may also have a population health tool and a separate vendor for example, telehealth. All of those things in their collective could be important to create that complete picture that we're looking at. So that would be just something to think about, perhaps looking at the class rankings and categories as a way to look a little bit more broadly.
Okay, so what I'm hearing in that, Brian, is just to make sure we get the recommendation down accurate, is that the little r recommendation is let's get our lexicon in order so that when we talk about EHR, HIE, whatever, that the language you just did was EHR and kind of the associated or satellite tools. And let's make sure we're using them consistently and that they're meaningful in the context. Did I get that right?
Yeah, I think that would be perfect and incredibly helpful. Yeah.
Okay. Sue Ellen?
Sorry, I didn't mean to talk on you. I was just going to say that maybe we do need to broaden the definition. That way we do include those, you know, the electronic health record as well as the solutions that go along with that, you know, such as telehealth. And not only that, but for healthcare institutions to be able to open up their records for maybe, you know, a collaborative effort, let's say with EMS or a community-based health partner, to be able to document within the patient's record, they would need to have a solution that would then draw that data in versus that direct access, let's say, to an EHR. And I don't want to get into a bunch of, you know, technical descriptions, but then that way you would be more inclusive, if you will, of everything that goes into it, like the gentleman prior to me was saying.
And Sue Ellen, I think that point that you're making, which is consistent, I think, with Brian, is let's make sure that the language we choose is inclusive, and it also that it speaks to the full group of stakeholders so that we're not using jargon here for the people we need to talk to, because one of our reports is for consumers. And we need to make sure that we are speaking meaningfully to everybody involved here.
Yes.
Okay, that was great. Russell?
Yeah, I just, I would like to propose, based on the last few comments, that the problem that we're trying to solve with respect to care coordination is that increasingly the electronic data of individuals is distributed across many systems. It wasn't true 40 years ago. It really wasn't even true 10 to 20 years ago, but it is becoming increasingly true that there are the things that we see on the screen in front of us, mobile devices, wearables, other sources. There's data in a lot of different systems, not just the EHR as that acronym used to imply.
I'm hearing that part of our recommendation, and haven't gotten this quite framed yet, but all of your comments are just incredibly helpful, which is the EHR, and our focus is EHR leverage measures, is in some way to represent that the EHR is a part of the whole, and that without seeing the whole, it's very hard to address the fact that we have data coming in from so many different systems.
Yes.
So I think, you know, that's going to be really something that we need to sink our teeth into. Rich, I'm going to give it back to you because I think some of the next themes are going to kind of, you know, reflect some similar things here. so that we don't necessarily need to repeat the recommendations as much as kind of expand and think deeply here. So if you're comfortable, let's go on to theme 2.
Yeah, thank you. And I think Chelsea wanted to make a bridging comment, but before I'll hand it to her, I just want to really thank the committee for the discussion today. Much of what we just discussed is not specific to theme 1. Thank you for that. And thank you so much for thinking so really disruptively. So Chelsea, why don't you make your bridging comment and then we'll move on to the second theme.
Sure. Thanks, Rich, and thank all of you. Similar to what Jerry was saying, and hearing the conversation today, that's something we can discuss with our CMS colleagues. But our scope of our project is really looking at the EHR, and so while there are the EHR-based tools and like this whole satellite system that really should be considered, I think we may be focusing more on like what can the EHR do, with the recommendations being it needs to make these communication connections. So it may be framed in a way that is just coming from the EHR, because for us to leverage EHR source measures, we do need that data in the EHR, but understanding that that data needs to come from all of these satellite tools that are there. So I think we're definitely moving in the right direction, and then it'll just be making those links to have that a really great EHR for one patient, understanding that it then also needs to go to an information exchange so that information can be shared across providers. So I think we're definitely heading in the right direction there, and I think more and more apparent of how much work we'll have to do in terms of recommendations and to get there. But and similarly, a lot of these themes have a lot of overlapping pieces. So we'll go ahead and move on to the next theme, which is about sharing the actual EHR data. So certainly once it's in the EHR, which we know there's issues with quality and availability of the data in there, but then also sharing that. So we've noted lack of interoperability, as well as lack of access, whether that be, within one healthcare system, across different healthcare systems, across, independent organizations with different EHR vendors. How does that information go? How does that impact the health information exchanges? Keeping an eye on the rapidly changing healthcare information technology innovation that constantly occurs. So these are just some of the different topics that would kind of fall under the sharing of EHR data to make sure that we're staying on top of everything.
Thank you, Chelsea. So let's go ahead and open this up. So under the notion of EHR data, and I can totally appreciate how many of the points that were raised in the prior theme will come into play here. And I want to emphasize what Chelsea just said. We need to keep in mind where we're trying to land, but we also need to be mindful that we're going to have to figure out how to sequence this in a way so that we can move the field forward. So let's open this up now for the sharing EHR data theme. Let's see. Okay, Sue Ellen. We've got a couple of chats here. Feel free to raise your hand if you'd like to turn it into a verbal comment or question.
Actually, I was just clarifying with Chelsea to make sure that I understood what she was saying. And yeah.
Okay.
Yeah, and I think a very important point of maintaining security and privacy, for sure. Definitely appreciate you highlighting that important aspect.
Rich, would you or Chelsea remind us what we meant by democratized data?
I'll go first with that. So the meeting that I recall it being brought up was this notion that that the data has the ability to, if not the expectation, that it needs to be available to all appropriate users within a secure realm, of course. And I think that there are certain types of data that just makes sense to be available in a timely fashion to all necessary team members. Chelsea, is there a different aspect of that or an additional aspect?
Nope, I think that's right on.
Okay. Kim, I want to call on you because you also mentioned EHR costs in the last theme, and I want to be mindful that the diversity of the composition of our committee, especially for folks that aren't providers, might not really have a view of EHR costs at the level of practices. So for the sake of edification for the committee, could you say a few words, please, about that?
Yeah, I'd be happy to. A lot of times there are certain modules that are available for practices to purchase. When you have an EHR, you'll get a standard package. But then there'll be other modules that will allow you to have more interoperability or allow you to have access to more data. But you have to pay for that. And the cost can be really quite considerable for a practice, like anywhere from, $50,000 to $100,000 or even more. And so for some practices that becomes untenable, where you're sitting there going, I can't afford $200,000 right now, or they may have a system that's integrated with their local hospital, but there's another hospital down the street. And so because they get the hospital, they don't get anything from the other hospital unless they pay for something for that hospital. So it becomes a real barrier to be able to get data on the patients that are cared for at those hospitals. So that's one area I see a big barrier. And I've even seen this even within practices that refer to certain hospitals where they just don't have the right modules for even if it's the same EHR. They're both on Epic, but they have a slightly different, whatever. And the information in one place is not seen at the other, and nobody knows what's happening with the patient. So it just becomes really, really quite awful and dreadful, quite honestly.
And Kim, thank you for that. That kind of sends shivers down my spine, not as a clinician so much, but as an advocate for equitable outcomes. So it almost is, if you've got more resources, you're more likely to have access to all the necessary data to provide an integrated, coordinated plan of care. So I really am grateful that you called that out. That said, I'm not going to parking lot the cost factor, but in fact, let's sort of keep that relatively top of mind. So as we come up with reflections about adequacy, gaps, refinement, and potential recommendations, I want to make sure that equity and sustainability for all providers, for all care recipients is where we're trying to land with this. So I'm getting a flurry of chats. Brian and Russell, I see an interesting point that you've raised about interoperability, and I think it would also benefit the committee. If one or both of you guys want to talk a little bit about what you mean by that, because it certainly is relevant to this conversation.
Yeah, this is Russ Leftwich. The idea of moving everything to the EHR, if the EHR is an organizational EHR system, is to me a 20th century idea. It is no longer possible. There is too much data that is outside the EHR in many places, important data, too much data to move into the EHR. It's just not technically feasible anymore. And that's not the way we do it in other domains, if you will. My comment in the chat, when you don't download all your Facebook friends' pages to your EHR, you see them on their systems from your EHR. From your computer. You see them in one place, but they're really still in the places that your friends are. I think the future of healthcare interoperability is somewhat the same. That the data is distributed. We have to adopt the technology, which is usually called the World Wide Web, to seed data in many systems from a single system, as if it was there. The federal rules around interoperability that started to go into effect the end of last year are recognizing that, and maybe this committee should have a presentation or review of those federal rules on data democratization, if you will, and data sharing, that say that every individual has the right to access all of their data in any EHR system as sort of the foundation of those rules. But then it goes on to specify the technology to do that, which makes it possible to do what you do on Facebook, if you will.
Thank you for that. And Mike Lieberman, I know your hand is up. Is your comment about this topic? As otherwise, I was actually going to ask Joel to verbally elaborate on the point he put in the chat, but I'll give you first dibs, Mike.
Well, first of all, I just wanted to say, kind of piggyback on Kim's comment that data sharing is difficult. I mean, even from Epic to Epic systems, just that as an example, we've been trying to share obstetric data, like prenatal data that's collected in an ambulatory system with a hospital that is then where the patient's going to deliver. And while all the data is in Epic, it's in different parts of Epic, and it gets to be very difficult. So I think that it is, how do you share the data really comes down to data models and discrete data, and how do you share it discretely. That was the main thing. I could comment on Russell's as well, but I'll defer to let others go first.
Joel, you've put two comments in, so if you wouldn't mind, if you could weigh in on this. And I want to acknowledge this notion that there are rules that are moving us in this direction. It would behoove our committee to heed what those rules are, at least the directionality of in our work. So Joel, would you unpack your two comments for us, please? Joel, are you muted?
I don't know why you would think that. Sorry about that. Yeah, good afternoon, everyone. My name is Joel Andrus. I'm leading the digital quality measure transition work at CMS's quality reporting programs in the quality measurement value-based incentives group under Michelle Schreiber. So we've been running around talking about our blueprint for this transition for a while, well, for the past year or so. We've also been kind of working with some of our partners at ONC and other federal organizations to push forward a number of pieces of that blueprint. The one that I mentioned in my first comment is dealing with the idea of data standardization, which is to say you need a baseline understanding not only of the format that data are to be available in or to be captured in, or at least mapped to once they've been captured, because many tools use different standards for capturing their data, at least initially. But you also need to have a common expectation of what data should be available within the overarching system in order to be able to predictably understand what data you're going to be able to access, not just for quality reporting programs, but for other use cases as well. And so part of what the US CDI, so the US CDI is sort of the foundation of these two interoperability rules that you're referring to from CMS and ONC. But they're really just identifying broad categories of data that need to be captured. And there's a lot more that goes into identifying specific use cases. So one of the things that we encountered at ONC is when we first last year for version 2 submitted our recommendations for quality measurement based data elements. And we really just pulled data elements that we identified from our existing ECQM set as being appropriate for it. one of the things that we ran into at ONC is their expectation that USCDI represents a core of the clinical data elements. And, you know, in talking about this, we you know, I think both groups recognized one, you know, there's some justification for having a core set that's common across all data systems, and then not all data needs that we can identify for all use cases necessarily belongs in a core set. On the other hand, you need to be able to capture standardized requirements for those use cases within the context of that core, because the core won't meet all the needs for those use cases. And that's what the USCDI Plus initiative that ONC announced here, I think at the beginning of October, end of September, is kind of driving that. And we've been working with them to sort of model out what that might look like for the quality measurement use case in particular. But in talking with them and talking with other you know, stakeholders in this space, one of the things we've identified is that yes, you can set out this set of requirements for fire, but one of the core elements to sort of our map of how we think the blueprint can work is that vendors and providers are still responsible for taking that initial set of data from all of these sources, and we were talking about this earlier, right? All the many different places that data now come from, and then being able to consistently map it to those specified API endpoints for transmission via FHIR API. And so I think so that led me to my second comment here, which is you have, or leads me to the kind of end of that comment, which is, you know, there's going to have to at some point be some understanding of how that enterprise is undertaken in a way that's done consistently across the board. And that's not really the province of the current levers that we have for accomplishing this, right? So most of the levers that CMS has is either through quality reporting programs or through the certification requirements, the CERT program. We don't necessarily have any insight into how data elements would potentially be mapped to FHIR in the first place. And I think my question is really getting to the point of, you know, these other sources of data capture are being developed, they're being maintained within with a business need to serve medical providers and patients' needs. And so it was really kind of getting at how do we push forward an effort so that the originating data are aligned with what are going to be needed to meet the cases for interoperability. Because you can keep developing those tools to provide a, you know, kind of an immediate need for the point, but unless they're ultimately feeding into this case for interoperability and a variety of use cases that are around that, you're going to run into the same issue as before. It's going to cost to integrate it, it's going to cost to translate it, and it's going to cost to bring in. And I think that's a cost that has to be paid because I think we have to push toward interoperability regardless of what it ultimately entails. I think that's a need and not an option in the healthcare system. But we need to identify ways that we can facilitate that integration without, you know, driving people to a choice between bankruptcy and participation. And I don't have the answer for that, so that was why I posted my comment.
So this is really, really helpful, and I appreciate your putting it in the chat as well. I'll sort of take a step back. I'm going to leave to Jerry to do the recommendations discussion in a little bit, but I just want to make the following observation. So to the extent that there is let's call it a glide path to interoperability that this committee needs to be aware of, because the charge to us is around what would be those indicators, the measures, if you will, around communication, care communication and care coordination going forward. So thank you for that timely input. I think that I have Russell's hand is up.
Let me see if I can sum up in 3 minutes the interoperability aspect of the recently implemented federal rules. So that the federal rules require that every EHR system have an API, and an API that's application program interface, which basically is the way one computer asks another computer for data and what it gets back in return. And every EHR has to implement an API according to the Fast Healthcare Interoperability Data Standard, which is usually referred to as FHIR. Every EHR has to implement the same API, so it's a publicly defined API, and it eliminates the previously existing problem of, I don't know where in Epic that is stored, because there's only one API, and you ask that one API for the data you want, and you get back the data that you asked for in a particular format. And I would agree that the US CDI, which is the US Core Data for Interoperability, is not perfect, but it's a good start, and it does cover the vast majority of what we would need for care coordination and communication around it. And it defines the way that those data concepts are represented in every EHR, regardless of which EHR. So you don't have to worry about how the EHR stores it or where it stores it. That's the intent of the current CMS and ONC federal rules, and I'm reasonably optimistic about it.
So Russell, at the extent of asking a really naive follow-up question, might the core of the recommendations, capital R recommendations that come out of this committee, actually be aimed at the elements of an API?
Yes, yes. And alongside that API, in the Health Level 7 standards organization, there are initiatives around transitioning from the decade-old version of equality measures to a new version that is based on that FHIR data standard. And a part of that FHIR data standard, which is CQL, clinical quality language, that is a specification of the logic for quality measures and decision support. That's the flip side of them. And there is a roadmap in the relatively short term. We're sort of halfway through that conversion from the previous quality data model and electronic quality measure specifications to this future version of those qualifications, quality measure specifications. And I certainly think we should be aiming for that, you know, a few years away future version of that electronic representation of quality measures. There is a roadmap and a transition in progress, and we're sort of halfway through it right now.
So I want to acknowledge the important comments from Joel, and then also Russell. This is really, really helpful because it gives a framework for our committee to be able to comment too. And I want to quickly jump back. I saw a comment here. Fran at 316, and I want to get this voice here because it's an important voice. Can you give us a little bit of more elaboration on your comment around Joel said at 315, and then Fran, I really like how simple your comment is, but I want the committee to hear it.
Yeah, hi, thank you. So one of the problems that we struggle with in VA, having 130 different sites, is that the same data gets repeated in similar but different fashions multiple times in the medical record, and it makes it extremely difficult for the providers and I'm sure even the veterans, although I haven't looked at it through their portal, to actually understand what's going on. You know, when you're looking at a problem list in our version of the Health Information Exchange, the JLV, you can have a medication list that has medications repeated multiple times. So it looks like they have the same active med, maybe even with different doses because they visited different facilities and it's located in each one. So when we're talking about how to represent data, we have to ensure, one, that we can see it appropriately, that we don't get different versions of the same record, but the integrity is not maintained because it's being harmonized or normalized incorrectly. And then we need to make sure that when we're looking at records that there's some way to deduplicate similar and or even conflicting data, you know, flag that to the end user. Especially now that we're starting to work with things, you know, like AI and trying to mine data repositories for information, the qualifiers on a term can be located very far in the medical record and may be disconnected from it. So something that's negative may actually be recorded as being positive. So when you start thinking about how all of these health records are communicating, there's a lot of thought that needs to go into how we're normalizing the data, harmonizing the data, and reducing the data to the minimum number of representative factors, if that makes sense.
Actually, it does, and I'm sort of hearkening back to our theme 1 discussion about the data quality. So thank you for that. I'm not seeing any hands up now, so let me hand it over to Jerry for defining what some small R recommendations would be in this incredibly robust discussion.
This is an absolutely fantastic discussion, and it strikes me that it's foundational for all of our recommendations. So the fact that we're spending a lot of time on this piece is really, really important, and we'll just kind of figure out how to balance all of it, because this sets the stage for talking about the measures, how they get shared, and so forth. So what I'm hearing, let me put these out as small r that we come back to, which is this whole idea of EHR and its relationship to other systems is really critical for all of us on the committee to understand. And I am so excited, and I want to applaud that we have so much input going on in the chat, in the discussion from both our committee members as well as our federal liaisons. So fantastic. Is the relationship between the EHR and other systems, and going back to what several of you have recommended, one of the backdrop things that we probably need to think about through email is, for those of us, and I'll count myself among, is not understanding all of these issues that are flying by that seem absolutely critical. So what kinds of background information do committee members feel would be helpful, whether it be the federal rules or the background on the conversation about API, just so that we are kind of at a similar kind of place of understanding. So the relationships, I think Joel made a very strong case for data standardization, which we have across several of our themes, as well as what Rich was talking about is understanding the glide path to interoperability and what will be recommendations that get us to the place of using the EHR effectively for care coordination. There's the issues that were brought up related to understanding costs that is not on this, so that's a gap area, as well as data burden. And one thing that I would recommend to the NQF team to see if there's anything that we are overlooking in small R kind of conversations is there is so much specificity in the chat that can we look at how to make sure we are attending to that level of specificity. So what am I missing in terms of small R recommendations moving forward? So to repeat, EHR and other systems, how they communicate equity, data standardization, moving towards interoperability and the costs associated with it, and data burden. What else? Either chat or put your hand up. Okay, Fran, do you want to turn that into a small R recommendation that we think about?
Turn which in what I just wrote in the chat or what I was saying before?
What you just wrote, or either.
Well, I mean, you know, one is the small R is to come up with an appropriate language. And, you know, I was just at AMIA last week, and it's something that people are thinking about is that common language. How is data in the electronic health record going to be represented? You know, if you go to plug your plug into any socket in the United States, they're all the same, you know, AC current, you know, uses the same size plugs and everything. And if you think about that in the form of an electronic health record, we pretty much said, okay, you know, use your data. It doesn't matter what form it's in. If it's in your data record and you can get to it, that's fine. But they didn't consider that other data records might want to plug into it, or that data may need to go somewhere else that doesn't have a receptacle that's going to fit that data record. So, you know, I think we really have to go back to the basics if we want to successfully be able to represent and share our data across all these platforms, rather than trying to take 300 different systems and normalize them or use, you know, like the Babelfish of electronic health records to communicate across them. We really need to say is, look, guys, this is it. Enough is enough. We all need to speak English, or we all need to speak electronic health record and have that common language. And then we also need to prevent and I don't, maybe this is radical or impossible, but we shouldn't be ingesting and utilizing somebody else's data in our data record. We should be viewing it. I mean, even within the electronic health record itself, when you have a finding, you shouldn't cut and paste that finding into your note. You should reference the original object. And by the way that it's grown up, you know, out of kind of a paper type environment where everything's written down and repeated, because you don't have that indexing capability. I mean, this is what computers do really well. You put a pointer in a record and it tells you where it came from. Why are we cutting and pasting the information? And then it gets changed and you lose your provenance, and you lose your codifiers, you know, and that becomes it does. And so unless we create an underlying set of rules, I don't think we're going to be able to solve this problem. That's just my opinion. I'm not.
It's called the FHIR API. It's called the FHIR API.
Yeah, I agree to a certain extent, but we still won't. That won't prevent the duplication. I mean, we have to also. I think there has to be legislation or standards, organizations that like the ISO needs to step in and say, look, you know, you can't have an electronic health record, and these are the standards that you have within your record itself.
HL7 has done that. And
yeah,
that is what the federal,
so
federal
just
rules point to.
you know, I'm just wondering, we have spent a really important amount of time talking about EHR, how it relates to other systems, interoperability. We only have about 20 minutes left. So I want to just check in with our whole team here. We have not gotten into specifics of care coordination, measurement, the equity issues, and so forth. All of this is so foundational to getting to that place because care coordination does cross systems. It requires interoperability, and I think that's reflected in our themes. What do we want? Chelsea, maybe kind of weigh in here. We only have about 20 minutes left. What would be most helpful in terms of moving us forward?
Yeah, this has been a really great discussion and very heavy with lots of different aspects. I knew I was probably being a little overly optimistic, thinking we could get through all 10 recommendations and have an additional discussion on the side. So my apologies. I tend to be very optimistic, but I think for the next 15 minutes or so, I think we've talked a lot already about, how important the data is, getting the data into the EHR, sharing it. I think we already understand what those barriers are. I'm wondering if it would be good to either transition to thinking about what the equity considerations for the recommendations we want to develop, as well as, the measurement considerations for care communication and care coordination, and kind of understanding, how can we start moving beyond just checkbox measures, which of course will get into the data availability and all of these other things that have been so essential to what we've been talking about so far.
Okay, so Rich, how about if we look at theme 4, equity considerations, and realizing that we cannot do justice to it in 10 minutes, but at least start the discussion and then move into theme 6 of measurement considerations, just so that we can touch and get all kind of our juices going for the next meetings and the in-between. So do you want to just keep our same process and I'll just keep doing notes?
That's fine with me. And I appreciate the incredibly robust discussion to date. And I'm encouraged by the fact that there are some guideposts that we can follow. Equity is clearly cross-cutting. And so let's sort of move this forward. And we've touched a couple of opportunities. And Kim, in particular, your observation about providers bearing the cost to get certain functionality so that they get all the necessary data is really important for us to be thinking about equity at the provider level, and obviously, most importantly, equity at the level of the patient, the family that are receiving the services. So let's open this up in terms of the discussion that we've had for the theme around equity from the year one. Try to the extent that you just want to say, and this links to the comment we made on theme 1 and theme 2, that would be great. I don't think we have to spend more time about that, but let's focus on this cross-cutting measure. Kim's put in the chat, gender identity, sexual orientation. And did I hear somebody's jump in?
Yeah, it was me, Rich. I was thinking that a lot of our previous conversation has kind of, brought home to me, interoperability is absolutely foundational to equity. So let's, we can put that in our kind of, let's consider for recommendations. But what about the equity of bullet 3? Can people speak to the digital divide and patient access and what you're thinking about for what we can possibly do to move the needle on EHR leverage measures that has immediate impact for patient access?
Maureen?
Hi, guys. Can everybody hear me?
Yes.
So that's always my first question because I don't have enough bandwidth here in West Virginia to run my camera usually with the audio. And that is a connectivity issue that we deal with in Appalachia because of where we live. So, you know, patients in rural areas are automatically our access to digital portals, etc., are limited. Also, just real quick, I'd like to add, I'm a veteran, and I just wanted to speak to what Fran said. I think like the ISO involvement and some mainline like legislation that kind of streamlines what you're looking for in EHRs and how metrics and data should be compiled. Maybe it's a moonshot. I don't know much about tech, but I will tell you this, as a veteran, I don't utilize the VA system because it's not set up well for women. And when I've gone there in the past, I've had to cart my briefcase of medical records with me. Otherwise, they're looking at things that happened to me, you know, while I was on the USS Constellation, you know, 20 years ago, and I'm there to have, you know, some prenatal care or something. So that's just my real world kind of anecdotal like experience that I wanted to share with that. But as far as equity, when it comes to utilizing portals, yeah, we have a connectivity issue that absolutely requires legislation, which my state has been wrangling with for a while. But until that is fair and again equitable for everybody, I just don't see how it can work across the board for patients in general all the time.
Thank you for that. Dorothy, you always have wisdom. So can I ask you please to vocalize a little and elaborate on what you just put in the chat, please?
Yes. A lot of the patient and family members that I deal with, they have the phones that are very limited in service. It seemed to be the only thing that they're able to do is to make connection with perhaps a family member and say, I'm doing well, or the phone for a 911. But they do not have the capability to even have a telehealth conference, Zoom call with their physician. So again, not only having, you know, as as Maureen was saying, from her perspective, from, you know, her being a provider of service, but it also impacts the person or the individual receiving the service.
Thank you. That's critically important and is a profound contributor to disparity, isn't it? And so I really feel this view of infrastructure and getting there. Joel, I really think that the point you just put in the chat is really important. I often go to meetings where people show me quality data and they can't tell me how are they stratifying by race, ethnicity, language, disability. And I think the whole SDOH piece is important. So can you unpack that a little bit? This clearly has significant implications for looking at equity going forward.
Sure. So this was one of the domains that I think got more headway in last year's version 2 of USCDI than I think had initially been planned. And I think part of that was because ONC had been kind of intentionally toning down its any increases in requirements during the pandemic. They weren't wanting to put too much in at that point, but also because there is I think here recently a renewed interest in social determinants of health. The way they started structuring it is that you have fields for SDOH data within the various domains, so it's not like segregated out from the other data fields as its own domain, but it's kind of spread out throughout the other existing fields. And my understanding is that they're planning to take that approach on for the foreseeable future. We talked a little bit with the Gravity Project leadership about ongoing efforts. I think they didn't submit anything for this year, but they are currently pushing forward additional standards for development for future years. And in talking, and one of the things that Michelle Schreiber, made clear, I think, in talking with the committee, the HITAC committee, is that CMS intends to support inclusion of the standards that the Gravity Project is pushing forward for a variety of categories of social determinants of health and data, not just the ones mentioned above. And so I think what that means is the Gravity Project offers a fairly convenient vehicle for taking forward recommendations for new standards for development. So one thing that might make sense for this group to do is to contemplate what standards would need to be considered, and then communicate directly with the Gravity Project team to start about those recommendations, so that they can take it into their process and begin working on standards development. So I just wanted to lay that out there as a discrete recommendation that I think you could probably get some pretty substantial traction on with a defined process for moving the standards forward.
That is absolutely wonderful. Thank you. Kim, and then Jerry, you're in the on deck circle. Kim, you're next.
Yeah, I just wanted to say my comment about the gender identification is that within EHRs, even though, they often will state the gender identity of the patient, it's in different parts of the EHR, and it really needs to be standardized, because many times, whether they list all the different genders there, it's very variable. And we've done research within our different practices and different EHRs of trying to find out, how many trans women there are or trans males, and it's just almost impossible. It's very difficult. So I think that is something that really would be wonderful. EHRs would actually get together and figure out where that information should be, and whether there be a standardized set that is put there. When it comes to SDOH data collection, even within the EHRs, it's become very challenging, because many times we're using social determinants type of questionnaires to get that data, and then you end up either faxing, scanning it into the EHR rather than actually getting it into specific parts of the EHR to be able to get later on. So I think there's difficulties with being collect in a way without being burdensome for the practice, where you have someone spending an hour collecting information on one patient, for example, for social determinants. That's not tenable. That's not going to be scalable, right? So being able to find ways that we can get that information into the EHRs. And that's why I was saying that use of Z codes, oftentimes if somebody has actually identified a patient is poverty stricken and uses a Z code for that, if there was a way that could automatically be put into some part of the EHR without having someone else having to scan something in or put it in to a different field, that would be amazing.
Thank you. All right, and so Jerry, the timing of your chat is apt. I'll hand it to you for the recommendation portion before we hand it back to Chelsea to close us out.
Okay, thanks, Rich. This was a fabulous discussion. So yay us. This was a very successful first meeting. As I've written to y'all in chat, we've begun to generate a whole bunch of small R recommendations. And so we have not gotten through all the themes, but as we mentioned, they're cross-cutting. So what I would just ask everybody to do, if there are any that you want to get into the chat, please do so. Otherwise, I think we have many related to the first couple of themes related to EHR, where it sits in the context of other data systems, and as well as many other issues that go along with it, interoperability, cost, burden. And we just kind of began to cover the surface of the equity considerations. And thanks to those of you who had put in several related to SDOH, caregivers and consumers and connectivity. So lots and lots of food for thought. The other thing that going forward would, I think, be very helpful to all of us is if you would also share if there are any areas that you would like to kind of shore up your own knowledge, so that as we move forward in recommendations, you know, you have the information that you think would be helpful. So I think we have been very successful in generating small R recommendations that, Chelsea, I think we will be able to kind of put together and share with folks for meetings 2 and so forth. And we will be talking about having conversations on email so that we can keep this work moving forward very fluidly. I think we all realize it's critical work and it's going to move pretty quickly. So Chelsea, I'm going to turn it back over to you.
Wonderful. And thank you, Jerry, and thanks to all of you. I'll hand it over to Victoria in just a second, but I just wanted to highlight what Jerry just said. We will be following up via email since we weren't able to kind of cover everything. So expect some email and another opportunity to share your thoughts about what we've discussed so far, as well as all of the things we weren't able to get to, but really setting a really strong foundation for what we want to tackle in the upcoming meetings in January, February, and March, and further igniting my desire to do breakout groups so we can split our discussion into 2 and talk about even more topics. So really appreciate that takeaway from today, but I will go ahead and hand it over to Victoria.
Thank you, Chelsea. I will now open up public commenting to our members and those in the public. So if anyone has anything to comment, please go ahead and raise your hands or unmute yourself if you're on the phone lines. This is now your opportunity. Don't see any hands raised. Again, if you're on the phone lines, you can unmute yourself, or you can raise your hand or drop a comment in the chat function for anything we discussed today. I'm acknowledging a comment from Joel Andrus in the chat. Thank you. Other than that, I do not see any other comments. Thank you. I will move on. I will now go over next steps. So as always, please feel free to submit any additional inputs on the base year themes and ideal capabilities and capacities of EHRs via email to our project inbox, which you'll see here below, ehrcarecoordination@qualityforum.org. Please take note that our next web meeting will be held on Thursday, January 13th, 2022 from 2 to 4 p.m. Eastern Time. Please save the date for all web meetings, and you can always contact the project team with any questions or if you did not receive any meeting invitations. And like Chelsea mentioned, we'll be following up later today with an email on how to submit additional feedback on the base year themes. And I'll turn it back to Chelsea.
Wonderful. Thank you, Victoria, and thank all of you for your time today. As we've already said a couple of times, it's been a really great discussion. And considering Veterans Day is November 11th, which is on Thursday, we do want to take a second to thank all of our veterans who are on our committee for your service, and to all of your families as well. So thank you all for a wonderful discussion today. We look forward to seeing you in January, February, and March. So we will definitely be kicking this off and keep rolling into the new year. And we will be sharing things via email as well as discussion guides and things like that to really try to set the foundation for these discussions. And just really appreciate all of your time and hope you have a great rest of your Monday. Thank you, everyone.
Thanks.